Thank you for the introduction, and I would like to thank the organizers for inviting me to come here and present the loop study. We know that atrial fibrillation is associated with an up to 5 times increased risk of stroke and also an increased mortality. We also know that a lot of patients with atrial fibrillation do not have symptoms and therefore remain undiagnosed. A lot of stroke patients have undiagnosed atrial fibrillation, and we have a very effective treatment to avoid the patients having strokes. So the aims of the loop study was to investigate whether continuous monitoring for unknown atrial fibrillation and initiation of oral anticoagulation, if atrial fibrillation was detected, could prevent stroke in patients at high risk of stroke. The loop study is an investigator-initiated randomized controlled trial. Patients were identified from Danish registries and recruited from 4 Danish centers covering 3 of the 5 regions in Denmark. And the inclusion criteria were an age above 70 years and at least 1 of 4 diagnoses which gave an increased risk of stroke, either hypertension, diabetes, heart failure, or a previous stroke. And the exclusion criteria were known atrial fibrillation, an implanted pacemaker, ongoing oral anticoagulation, or a contraindication to oral anticoagulation. And the patients who were eligible for inclusion were randomized in a 1:3 ratio to either ILR treatment or control. In the ILR group, the participants received an implantable loop recorder, and we choose to use the Reveal Link device from Medtronic with continuous remote monitoring. Atrial fibrillation episodes were adjudicated by at least 2 senior cardiologists, and if we diagnosed atrial fibrillation episodes with a duration of more than 6 minutes, this gave indication for oral anticoagulation. This is just the consort diagram. The patients were included from January 2014 to May 2016, and a total of 6,004 participants underwent randomization. 1,501 were assigned to the ILR group, and 4,503 were assigned to the control group. And we had complete outcome status in both groups at the end of follow-up. And the median follow-up time was 65 months. Just some brief baseline characteristics. There was a balanced gender ratio with 47% females in both groups. The mean age was 75 years, and with respect to comorbidities, 91% of participants had hypertension, 28% had diabetes, 4% had heart failure, and 17% had a previous stroke. And the median CHA2DS2-VASc score was 4 in both groups. Atrial fibrillation was diagnosed in a total of 1,027 participants, 32% in the ILR group versus 12% in the control group. And the median duration of monitoring in the ILR group was 3.3 years. With respect to oral anticoagulation was initiated in 1,036 participants, 30% in the ILR group versus 13% in the control group. And in the ILR group, 91% of patients with atrial fibrillation received oral anticoagulation, whereas in the control group, 87% of patients with atrial fibrillation initiated oral anticoagulation. And the slide shows the cumulative incidence over time in the two groups. Now to the primary outcome. The primary outcome, which was stroke or systemic arterial embolism, occurred in 318 participants, 4.5% in the ILR group versus 5.6% in the control group. We found a hazard ratio of 0.80, which was not statistically significant. With respect to secondary outcomes, death from any cause occurred in 675 participants, 11% in both groups, no difference with respect to all-cause mortality. Hemorrhagic stroke occurred in 45 participants, 0.8% in both groups, no difference. And now to some subgroup analysis. The only baseline measure where there was a difference was the systolic blood pressure at baseline. And here we saw that in the tertile of patients with the highest systolic blood pressure, which was above 157 millimeters of mercury, there was a tendency to benefit if you were in the ILR group, and this was statistically significant when tested for interaction. We performed a pre-specified sensitivity analysis of the primary outcome, which included only participants who received the whole assigned intervention for a period of at least 3 years. And the sensitivity analysis identified 307 primary outcomes. And here there was a statistically significant difference between the two groups. So in conclusion, in individuals at high risk of stroke, ILR screening resulted in a 3 times increase in AF detection and initiation of oral anticoagulation, but no significant reduction in stroke or systemic arterial embolism. Although atrial fibrillation was diagnosed in more than 30% of participants in the ILR group, and 91% of these initiated oral anticoagulation, the risk reduction by intention to treat was only 20% and non-significant. There was no effect on mortality, and rates of bleeding were modest despite the low threshold for initiation of oral anticoagulation. And if you want to read more, the paper was published in The Lancet. And just to acknowledge all the study participants and the steering committee and authors, international advisors, study nurses, and our founding sources. Thank you very much.